Good evening, everyone, and welcome to tonight's Travelling Safe Travel Medicine Update. My name is Penny, and I am your host for this evening. Tonight, I am joined by your facilitator, Dr. Tim Senior, and presenters, Dr. Vicky Shepherd and Professor Nick Swar. Before we begin, I would like to make an acknowledgement to country. We recognise the traditional custodians of the land and sea on which we live and work. Now, our facilitator for this evening is Dr. Tim Senior. Originally trained in the UK, Tim is a GP working at Tharawal Aboriginal Corporation in southwestern Sydney, in between lecturing at UWS and acting as the medical advisor for the National Faculty of Aboriginal and Torres Strait Islander Health here at the RACGP. A big welcome to Tim. We are also joined by Dr. Vicky Shepherd. Vicky is a public health physician who has been working for New South Wales Health since 1999. Vicky's current role is the Director, Communicable Diseases Branch, Health Protection New South Wales. This role includes overseeing surveillance of notifiable diseases in New South Wales, coordinating communicable disease control activities, oversight of immunisation programs including delivery of the school-based adolescent vaccination program, and representing New South Wales on Communicable Disease Network Australia. Previously, Vicky managed health protection services in the Nepean Blue Mountains and Western Sydney local health districts from 2008 to 2013. And welcome to Vicky. Presenting alongside Vicky tonight is Professor Nick Swar. Nick is a Professor of General Practice at UNSW Australia, School of Public Health and Community Medicine. He's also the Director at UNSW Australia Centre for Primary Health Care and Equity, and is the RAC representative on the Australian Travel Health Advisory Group, and is also a board member here at the RACGP New South Wales and ACT faculty. Big welcome to Tim, Vicky and Nick. I'm now going to hand over to Tim, who will take you through the learning outcomes.
Thank you very much. Welcome to everyone online. We've got a lot of you online and a lot to get through tonight, so we're going to try and squeeze it all in. This first slide that you're looking at now is the learning outcomes, and that's what we hope that you'll know when you've completed the this online webinar. So I hope that you'll be able to understand and refer to the 3 R's when advising travelling patients about vaccinations, and assess travelling patients about which vaccinations they need. Discuss some of the up-to-date vaccines available, including their risk and benefit and what the recommendations are for them, and then refer to relevant guidelines and websites for accurate, timely information. So that's what we hope you will get out of tonight. One of the important things, and we'll ask Nick to talk about this in a moment, is that while we're concentrating on vaccinations tonight, it's worth remembering that the consultations that we have with our patients before they travel cover a lot more than vaccinations. And the next slide, I invite Nick to talk a little bit more about just briefly some of the other things we need to cover when we're talking about people before they travel overseas.
Yeah, thanks, Tim. Yeah, there's a lot to cover in a consultation for pre-travel health advice. Risk assessment is a big part of that. This traveller for this trip at this time is one way of thinking about that. But we need to think about the travellers more broadly, their past history, you know, what chronic illnesses they might have, what previous exposures and immunisations they may have had, what they're doing on their trip, obviously, and think about, as the slide shows, as well as immunisation, sometimes chemoprophylaxis, particularly for malaria, and advice about self-treatment, which is a bit different to perhaps what we might do if this person was staying in Australia.
And so the next slide here shows the different risks of different areas that people might travel to.
Yeah, it varies around the world, as this slide shows, and this is kind of high-level data, really, trying to kind of give an idea of risk in different parts of the world. If you want to go somewhere really safe, New Zealand is about as safe as you can get, as long as you don't kind of go flying over glaciers. But, you know, obviously in various forms of infectious disease and vaccine preventable disease in different parts of the world, and of course malaria, particularly in West Africa, is a risk. But there's also malaria in our part of the world, of course, in Oceania, Solomon Islands, PNG, and a few other places. So yeah, various risks, they vary from country to country, and part of the job is thinking about risk in that destination for that traveller. And it'll vary. If someone's going to just stay in the city, you know, for a business trip, in a high, you know, and what a country that may have a lot of risks, they may not be at high risk. But if they're going to rural areas, longer term travel, that changes things substantially. So you do have to individualise it for the traveller and their particular itinerary.
Yeah, and I think the next slide goes over how we go about assessing some of those risks.
Yeah, and there's a lot to consider, and I won't go through them all, but you know, clearly that as we said, the traveller and their trip, and some people might be at higher risk because of pre-existing conditions, and then very much about the nature of their planned travel. Sometimes people are going really off the beaten track. Sometimes people are doing sort of higher risk activities, and sometimes they're travelling to areas where you know there's an outbreak. So this time, you know, or it might be a time of the year where certain diseases are more common, like mosquitoes might be more active in the wet season, for example, in Asia. So yeah, thinking about the travel.
And then the next slide shows us some of the topics that we might want to cover with people as well.
Yeah, there's a lot, and you know, you really would like your traveller to come in ideally 6 or 8 weeks before they leave and give you time to do this well. And so thinking about trying to encourage travellers to do that, and often it's necessary to schedule a second consultation, having done the sort of risk assessment, to then talk about these things and to provide the advice, maybe show people some various websites or give them some handouts, and to really you know, have a bit of a chance to do the health education that this involves. We need to remember, you know, older people are travelling more, people with special needs, people travelling on their own, particularly males. You think about STI risks, and travel insurance, really important to encourage all of our travellers to be insured.
Now, for some people who are less likely to come and seek travel advice?
Yeah, this is focusing on the visiting friends and relatives concept. I mean, many people in Australia were born in various countries. I mean, obviously we had the very large, quite large numbers of people coming in the 1970s and 80s from Vietnam, for example. More recently, other parts of the world, including Africa. These people do like to go back to their country of origin. Often they want to take their children with them. They're more likely to stay for longer periods. They're more likely to eat the local food. They're more likely to have greater interaction with local people. And they may not perceive themselves to be at risk, or their children to be at risk, because, you know, maybe they grew up in that country, they feel they know it well, maybe they didn't get much health problems when they were young or when they were there. But there is clearly evidence that they are at higher risk for a number of infectious diseases, and some of those are vaccine preventable diseases. And I think it's really general practitioners who might have an opportunity here to see these patients, to raise the issue, and it's particularly GPs who work, you know, whose practice includes those communities. You know, the people from the Indian subcontinent, the people from Vietnam, the people from Laos, the people from Cambodia, the people from Myanmar. And, you know, when they come in for other reasons, maybe it's an opportunity to say, have you thought about travel health? And one of the, I won't go on too long, but one of the things that people may not realise is if they grew up in a malaria endemic area and they got some community malaria due to recurrent exposure, that will disappear within a year of leaving the malarious area. And they're just as much at risk of getting a severe malaria, as someone who's never lived in that country. But many people don't realise that, and they don't realise that they are at risk.
Yeah, that's really important. And the next graph, we've got looking at hepatitis A notifications. What does this tell us?
Yeah, thanks, Tim. It's Vicky. I just thought I'd bring out some of our local data just to illustrate the experience we have in New South Wales of travel-related infections. This one here is hepatitis A for the past 5 years. And the things that we can note is that we see a peak most years in January, February. And that's with returning travellers, many of them from visiting friends and relatives, who, you know, they sometimes take their children over to India or Southeast Asia, and then they return and develop hepatitis A. In the most recent years, that's been a bit distorted because we did have our own local outbreak of hepatitis A with frozen berries, but you know that's certainly the general pattern we see and what we expect to see hepatitis A being introduced after the major summer travel period. And then the next one is typhoid, similar pattern, perhaps not as marked as fewer cases introduced. But again, the peak in most years is around that January, well, particularly January with the shorter incubation for typhoid when people return to Australia.
Excellent, thank you very much. Any tips on how to, on talking to people about educating them on travelling back to friends and family?
Yeah, well, I think, Tim, it's a really good question. I mean, I think it is awareness raising, GPs thinking about it. The GPs may well be aware about when their local community tends to have perhaps a religious event back in their country of origin, or when the popular time is for going back. People do tend to plan it a bit of a way ahead because they're often looking for, you know, the most economical deals on airfares. So there is sometimes an opportunity. You can put up posters in your you know, surgery to kind of, you know, travel health awareness materials. And I think also, you know, in the course of the discussion, just, you know, a quick question: are you thinking of travelling in the near future? Are you planning any trips home? It may be in just the kind of conversation we often have with our patients at the start of a consultation, that kind of, you know, social chit chat we do as part of the connection. That may be an opportunity to raise this. There have been other approaches. In Melbourne, I know in Victoria there was a awareness raising at some of the community events. I think it was for the Khmer community. That's an interesting approach. Clearly cost is a barrier to vaccination, but, you know, I think we need to be saying to our patients, look, if you're spending a significant amount of money on your airfares, you want to have a healthy trip, and it's, you know, vaccination is important. And think about your children. Because people might not realise, you know, they might have been become immune to hepatitis B, hepatitis A, for example, having grown up in a hepatitis A endemic country, but their kids won't be. They're very likely to be non-immune, having grown up in Australia, and they don't want their kids to be kind of bringing back Hep A from overseas. So I think it isn't easy, but it is really up to general practitioners to try and think about this.
Thank you very much. Now, we mentioned in the learning objectives the 3 R's. Vicky, what do the 3 R's mean?
Well, this helps me to remember, Tim, so I hope it's helpful for others. So the 3 R's as far as travel vaccination are routine, required and recommended. So we'll go through and talk about each of those, but basically routine are things that people should be having anyway, and top of mind there are things like measles and diphtheria and polio. So make sure that your patients are up to date with those vaccines, and that's reviewing their lifetime vaccination history. So if they're fully vaccinated as children, certain vaccines don't need to be repeated. And then there's a couple of required ones, and that's under the international health regulations, but only 2 or 3 of those, and we'll go through them. And then really bottom of the list are the recommended ones, and that's things like typhoid and cholera, which, as Nick's already alluded, you need to look at the very specific risks of your patient's travel to know whether those are going to be helpful vaccines. And I guess, you know, in doing this overall assessment, it's really important to remember if live vaccines are coming into the picture, you've got to make sure that you separate them by 4 weeks. So if, for example, a child needs a BCG and a measles vaccine, they need to be given on the same day, or you have to leave 4 weeks between the 2 of them.
And just to add to that, when you're thinking about live vaccines, of course, think about pregnancy, think about immunodeficiency, think about some of the contraindications to live vaccines.
So the first routine vaccine that we want to talk about was measles, and so really Australia has eliminated measles, so the only way that we get cases is when travellers bring it in, and that's mainly Australian travellers, sometimes people who are overseas travellers coming in, but in the main it's our own residents who travel overseas, not immune, and get exposed to measles there and then develop it either on the plane or once they get back to Australia. And this is mainly in young adults, and that's because they're in that group before the routine 1 and 4-year-old vaccination started, so they might have missed the primary school catch-up or the high school catch-ups that happened in the 90s. So we know about 20% of the young adult population, and when I say young, I'm saying up to about 45, about 20% aren't immune to measles. So, would really encourage it as a routine thing. Anyone who's under the age of 45, part of the pre-travel screen, do you have documentation of 2 doses of measles vaccine? And if not, you are very welcome to give them a free dose from the State Vaccine Centre, because, the last thing we want is them bringing back into Australia.
Excellent. And I think the next slide has some, these are the measles notifications here.
Yes, and again, this is some of our epidemiology over the past 5 years. The enormous peak that you see in 2012, that was 169 cases that followed the introduction of measles by one young man who acquired it in Thailand. And, on questioning, he didn't know whether he'd been vaccinated. His mum wasn't really sure either, but we can see that he wasn't. And then that took an enormous effort to control that outbreak. And then the other blips that we see from time to time are, again, introductions. So in early 2014, we had quite a peak, and that was related to Typhoon Haiyan in the Philippines, and an enormous outbreak of measles in the Philippines. So that frequent travel between Australia and the Philippines was introducing the infection to Australia. And so this kind of highlights one of Nick's points is about being aware of what's happening in the places of your patient's destination. So staying up with the latest epidemiology internationally.